PG lecture series. We are currently, actually today is our last lecture in the series of medical oncology. And before we start this lecture, I would like to thank the Department of Medical Oncology for taking the time out to give this series of lectures. They've been traveling to and fro between the two campuses to take the lecture for us, and we are very thankful to them. Today, we have an overview of gastrointestinal malignancies as the lecture for today, which Dr. Ajoy Oommen John, he's currently doing his DA Medical Oncology in the department here, has agreed to take for us. It's a vast topic, and I know sir has tried to put it together for us. So thank you so much, sir.
Hi, good afternoon. So the topic given here was overview of gastrointestinal malignancies, and that means asking me to cover esophagus, G-junction, stomach, hepatocellular carcinomas, biliary tract cancers, pancreas, colon, rectum. That's not possible. So it's not realistically possible to finish all that in 1 hour and take away anything useful from the lecture. So I'll just say a few things. There was a lecture taken 2 years ago by Dr. Raju on stomach cancers. It's on the YouTube channel. So I think you can just go back to that one. And last year, there was a lecture taken on biliary tract cancers and pancreatic malignancies by Dr. Ashish Singh. Okay. So I think since those two have been covered, relatively recently, I thought I'll focus more on the third one. Okay. And my job here today is hopefully to just get you sensitized to kind of what is the common presentations that we see. Also sensitize you to what are the tests that you should probably be ordering. And I'll give you an overview of how we approach this problem. I know that most of the time, once you see the diagnosis of cancer, that's it. It's over. Just call medical oncology. It's done. So I want to just give you an overview of what happens on the other side after the referral is done. What happens to your patient? Okay. So let's just start off with a few cases that I have. Okay. Right. So I want to kind of keep this interactive, okay, so that it's afternoon, everyone will want to sleep for some time. So we'll try and I'll be happy if I get some input from you guys as well. Okay. Right. So these are two cases that I thought would give you an overview of what we're going to discuss today. The first one is a 24-year-old farmer who presented to us with a history of abdomen pain for 1 month, which was in the right upper quadrant. It was dull aching initially and then later progressed to episodes of colicky abdomen pain. Later on, he had vomiting for about 3 days. That's what brought him to the hospital, which was multiple episodes since the day before his presentation. It was non-bilious, non-projectile vomiting. His past history is not significant. Okay. So anything you find that stands out to you in this history for this patient, 24-year-old man? Or let me ask you differently. Do you expect a 24-year-old person to come to you with colon cancer? Yeah. So the first thing is, if we do diagnose colon cancer, this is a colon cancer kind of focus lecture, so it's kind of clear where we're going. So do you expect 24-year-olds to have colon cancer? No, right? So when would you expect, or when would you see young onset colon cancers? Is there any, so any syndromes come to mind? Yeah, I'm hearing some words. Lynch syndrome, yeah, absolutely, yeah. Lynch syndrome, okay, FAP, right? So these are the things that your family history becomes very important. So I left it blank, right? Because we need to be focusing in history on does the patient have history of cancer? Does his family have history of colon cancers? Okay, in Lynch syndrome, what other cancers do you expect to see? Most commonly, let's not go into specifics, but very commonly, you get obviously colon cancer, as we're discussing. Apart from colon cancer, any other cancer that you expect to see with Lynch syndrome? More than ovary, breast? Endometrium, absolutely. Okay. So endometrial cancer is something. So these are the kind of history that you would focus on for this particular young patient who's coming to you with this history, right? Apart from that, so on examination, he was moderately built. His abdomen on examination was tense. He had tenderness in the upper part of the abdomen, but did not have rebound tenderness. And there were no masses palpable, nothing very useful we found on examination. Okay, so what would be the next steps in this patient's evaluation, right? So he's come to you, he's got pain, he's got multiplexes of vomiting, he has some features that maybe he's obstructing, he's got a tenseness and tenderness in the right upper quadrant, right? Any test that you would order, what would you do next? Yeah, you would like to do a CTS, okay? If you find a mass there, you would like to do a, so this patient, we did a CT, we found a hepatic flexure growth, okay? So in a hepatic flexure growth, what would you do next? For a hepatic flexure growth, you would want to do a colonoscopy for biopsy as well, okay? If he is in frank obstruction, you would need to do a surgery, yeah. So we'll discuss those details as we go along, okay? So this patient is a non-metastatic patient with a hepatic flexure growth, okay? Now let's go to the next patient, right? This is a 65-year-old lady. She's presented in February of this year with constipation for 1 month. And associated with the constipation, she had episodes of loose stools. So, and 1 episode of fresh blood in stools. On going back, she said she was perfectly well till February, then constipation, few episodes of loose stools, and then 1 episode of fresh blood in stools. She also had abdomen distension, which happened 1 month later. And on probing the history, we found history of involuntary weight loss and fatigue. Okay. So what do you think of in this scenario? So, like, I think this has been taught from right from MBS, where you find an older patient who comes to you with anemia or a change in bowel habits, you must suspect a large bowel malignancy, right? Okay. So on examination, she had pallor, which is otherwise thinly built, and there were no significant examination findings. Okay. So here we did the CT. Do you see anything on the CT? Okay. We found that. We also found the mass at the splenic, some thickening at the splenic flexure. So sometimes remember that CT alone may miss smaller growths within the bowel. So you need to do a colonoscopy, right? That showed a splenic flexure growth, which was obstructing. Okay. So what happens now? Biopsy is confirmed adenocarcinoma. So now we know she has a splenic flexure mass. It is kind of obstructing. She's got an adenocarcinoma, and she's got a metastatic disease, right? Okay. So now what do you do next?
Staging.
Staging. What do you like to do to stage? Staging. What would you like to do? Do we know the stage already? She's got metastasis. What's the stage? Yeah. So we already know the stage, right? Of course, we need to image the thorax, if that's what you meant. Yes, we need to do an imaging of the thorax, make sure that there is no other metastasis above the diaphragm. But apart from that, we do know the stage. Yes. And so I said she's obstructing. So what would you like to do? Yeah, she does need a surgery, and so that's what happened. So she had a surgery. You can see here the surgical histopath also confirms that she has adenocarcinoma, the hemicolectomy specimen. They've confirmed the stage. On pathology, it's T4. It's infiltrating through the bowel. Okay, and she's M1 because she's got a liver lesion that has not been taken out. That's why it doesn't come in the report. They've just addressed the obstruction. Okay, now look at all these things here. We'll discuss this as we go along. Okay. And hopefully you get a better picture of why we do these tests, okay? So we've seen here that this lady has a mutation in the KRAS gene, okay? So that means she has a KRAS mutant adenocarcinoma of the splenic flexure. Additionally, she has something called a microsatellite instability or MSI positivity, okay? So these are all some of the things that we're going to discuss today. So if you just keep these words in mind, and as we move on in the discussion, you will probably understand why we do these tests, what's the significance of it, and how does it change treatment. Okay. All right. So colon cancer is a global problem. Okay. From a population perspective, it is less of a major public health problem in India, but as our population ages, we will be just like every other developed country where it becomes more and more of a problem. Now, there are multiple factors for why you can develop colorectal adenocarcinomas. One is, of course, age. There is a definite association with older people. Having said that, there is a well-documented rise in early colon cancer, young onset colon cancers all over the world, even in India. Okay. So personal history is important. History of inflammatory bowel disease, etc., can predispose to colon cancers. Okay, and then there are these familial syndromes that we discussed very briefly. I won't go into all the details, but there are certain syndromes where you have a higher risk, a higher lifetime risk of colon cancer. Okay, now diet like red meat, processed meat, etc., can predispose for developing colon cancers, and physical inadequate activity, low fiber diet, obesity, diabetes, all of these are risk factors for developing colon cancer. So the symptoms, it can be very non-specific, where you have weight loss, fatigue. Sometimes you can have obstruction, like the patients we talked about. They can have anemia, right? They can have constipation, especially if it's on this side, constipation, alternating bowel habits, pain, etc. They can have, if you go down to the lower bowel, they can have a lot of fresh bleeding per rectum. And they, especially in the rectum also, they can present with both bleeding and obstruction. Okay. Do you know what is the meaning of the word tenesmus? What does it mean? So when you ask a history, the patient won't tell you I had tenesmus, right? That's an interpretation. How do you get that history? You know? Tenesmus is basically a sensation of wanting to pass stools, but then they go and nothing comes, right? So that's one of the histories that's one of the symptoms that they can have, especially in the proctosigmoid and rectum. Okay, and one of the signs is palpable mass and rectal examination, bright blood, etc. Okay, so the diagnosis standard is colonoscopy, right? We need to do a colonoscopy. It helps us to both get a tissue diagnosis. It helps us to assess the entire colon. Is it only one site of disease, multiple sites of disease? So for all these reasons, doing a colonoscopy is important. And the spread, it spreads through, or you can see all these mesenteric nodes depending on whether right or left. And the distant spread can be initially to the liver and then to the lung, right? So the liver is one of the most common sites where you see metastasis in colon cancer. Okay, and staging we said, so the steps involved are, right, initially history examination. You can do a CEA to assess if it's secretory or non-secretory. CT should be done to stage both the chest as well as the abdomen. And FDG PET is not recommended. Okay, so that's important to remember. So we sometimes think that the PET solves all the problems. It's not true. Okay, so a PET can sometimes miss, especially if you have mucinous adenocarcinoma. So if you remember the case I showed you earlier of the lady, the diagnosis said mucinous adenocarcinoma. So that's one of those histologies where PET is not sensitive. Okay, and for those with symptoms alone, you need to do additional tests. Okay. All right, staging. So everybody is scared of staging, but I'll simplify it for you. Anybody with a node positive disease is stage 3. Okay. Distant mets is stage 4. Okay, so stage 3 and 4 is sorted out. Okay. Now it's a question of stage 0, 1, and 2. Okay. So you can see here the distinctions between stage 2A, 2B, 2C. Those are details that you don't really need to know. But it's important to remember that when you have node positive disease, your chances of having a distant spread are higher. Okay. So metastatic disease is one side. Within the non-metastatic disease, we think of node positives as a very high risk group. Then you have stage 2, which is node negative, but within that we have high and low risk based on how big the tumor is. Obviously, a larger tumor, T3, T4 size, is going to be a high risk stage 2. An earlier stage T1 is going to be low risk. Okay, so that's clear. I think that's about all the outline that you need. Okay. All right. So the resection is, as you can see here, into a hemicolectomy, and these are the margins of how they would do a hemicolectomy. And this remains the initial standard treatment for a non-metastatic colon cancer. Okay. Now, obviously, this is a medicine lecture. Why we're talking about surgery, right? So, surgery has always been the standard treatment for a colon cancer, which is non-metastatic. Okay. So, for many years, that's all the treatment we had. But you can see here from this graph, as you go up the stages, you can see that the cure rates drop down. Okay. So, you can see very clearly that for a T1 node negative or even a T2 node negative, surgery is good enough. The patient is very likely to be cured with just that. But as you go down that graph all the way to the bottom, can you see the T3, N2 means significant number of nodes, okay? So as you go lower down the graph, you can see that the cure rates are dropping, right? So it's clear that surgery alone is not enough, right? And so that's where the concept of adjuvant chemotherapy comes in. Okay, what is the meaning of adjuvant? Adjuvant to surgery, in addition to surgery. Okay, so it's clear that surgery alone was not curing that group of patients. Okay, and so for that group of patients, we offer them adjuvant chemotherapy. Okay, we give it after the surgery, and the idea is we want to improve or decrease their chance of relapse and therefore improve their survival. Okay, so there are a few caveats here. It has to be started within 6 to 8 weeks of surgery. After 8 weeks of surgery, for every additional week delay, we know that their survival keeps falling down. Okay, and we use a combination of few drugs. We have only like 3-4 drugs here which are really important, which you probably need to know. How many of you have worked in medical? How many have come for rotation to medical oncology? Super. Okay. Do you know any chemos that we use for GI cancers? Any names that come to mind? Yeah, very good. Okay. So what is Folfox? Anybody knows what is Folfox? So Folfox is just a name for, so we have 5-FU and oxaliplatin, right? Oxaliplatin is a derivative. It's a platinum agent, like how we have cisplatin. We have an agent that is more specific for GI cancers called oxaliplatin. The combination of 5-FU and oxaliplatin is called Folfox. Okay. So Folfox, capecitabine is the oral prodrug of 5-FU. So instead of giving it IV, you can take an oral drug. So that's called Capox. So we use either Folfox or Capox as our adjuvant therapy for colon cancer. So after surgery, if you find the patient's risk is high, we would offer them adjuvant chemotherapy with Folfox or Capox. Okay, that's clear? So if you guys have questions, you'll stop me, otherwise you'll get lost. Okay, any questions so far?
Before surgery, some chemos are given.
So when you give chemotherapy before surgery, it's called neoadjuvant chemotherapy. Okay, so earlier there used to be only adjuvant chemotherapy because surgery was like I was showing you here, surgery was the treatment that was done for colon cancer, right? So then we started adjuvant, and now, well, in colon cancer we don't use neoadjuvant so much as a standard. Okay, where study is going on and all that, but then in rectal cancer we do. Okay, we'll discuss that towards the end maybe if we have time. Okay, so you can see here, this graph represents the cumulative benefits that you see after each step of treatment. So the blue represents the cure rate of surgery alone. Okay, the red represents the benefits that you give if you gave 5-FU alone after surgery, because first 5-FU was discovered first, so they used to give 5-FU alone after surgery. Then when oxaliplatin was discovered and they found regimens that were good, like Folfox, we added 5-FU and oxaliplatin together. And now we have enough data to actually kind of tease out what is the benefits that each of these drugs gives to the survival, right? So you can see here, for T1 node positive patients, 83% of them were cured anyway with surgery, right? Your benefit of giving the 5-FU was 6%, your benefit of giving that oxaliplatin was 2%. But as you go down the graph, you can see surgery alone is unlikely to cure this patient, right? When you added on the chemotherapy, you got so much benefit. So the message being that as you go into more and more advanced stages of disease, the surgery alone is unlikely to cure a patient. You need the adjuvant chemotherapy. And within that adjuvant chemotherapy, the 5FU is the most important agent. So if there's anything that you take away from this lecture, I want you to remember that 5FU is the main chemotherapy drug that we use for most GI cancers, definitely, and definitely for colon cancers. Okay. And oxaliplatin is the additional agent. It also has some benefit, but the major benefit of chemotherapy is with the 5FU. Okay. So this graph is okay with everyone, right? Now all these things come with toxicities. Okay. This graph is a little small, I know, but it's just depicting the toxicities that you can develop during chemotherapy. Does anybody know what toxicity you can have with oxaliplatin? Anybody knows? Come. I said we want interactive session. Come on. No, there's no cardiotoxicity. So this is something you must remember because remember, like I said in the beginning, GI cancer is going to become a more and more common scenario. And you will have patients who may have been exposed to chemotherapy sometime in their life. You're likely to encounter them during your career, right? So a few things that you must know. So oxaliplatin toxicity, any ideas? Super. Who said that? Well done. Okay. So peripheral neuropathy is the one that we're really worried about. Okay. So the peripheral neuropathy is cumulative. Okay. So obviously, if you give longer durations of chemo, the peripheral neuropathy is going to be more. And the neuropathy is largely non-reversible. Okay. So there's no point detecting a neuropathy after it's happened. You're already too late. You kind of need to prevent it from happening as much as possible and also prevent over-treatment for patients who don't need it. So remember the previous graph. See that many of the patients here probably didn't need that much oxaliplatin because only giving them a 2% absolute benefit, right? And then subjecting them to neuropathy is not fair, right? So that's what we're trying to balance. We're trying to balance benefits of chemotherapy versus the toxicity. So okay, I'm talking about so neuropathy is one major toxicity. The other one we're worried about with exposure to oxaliplatin is hepatotoxicity. They can have veno-occlusive disease. Okay. 5FU also has toxicities. Anybody knows about toxicity with 5FU or capecitabine? Anybody knows any toxicity that they can have? Super. Hand-foot syndrome. Yes. So capecitabine causes something called a hand-foot syndrome. Okay. So they come with hyperpigmentation, sometimes even peeling of skin. Okay. So all these are issues that need to be addressed. And that is toxicity that you have to decide, is it worth it for this patient to go through or not? Okay. And so there's been a lot of push to try and shorten the chemo. This graph is from a very, very, very large study that was done, trying to show that for some patients, even 3 months of treatment is enough. You don't need to give 6 months of treatment. And they also showed for those patients who had 3 months of treatment, they had no decrement in survival and they had significant lower neuropathy. Okay. So my take home here is there is a group of patients who are not cured by surgery alone, probably the more advanced ones. Within that group, there is a group of patients who probably don't need 6 months of treatment, they need only 3 months of treatment. Okay. And the decisions on treatments are individualized. Okay. All right. So that covers our non-metastatic disease discussion. So if you remember the first case I showed you, that gentleman had a non-metastatic right hepatic flexure mass, right? Okay. So the first step, like you all correctly said, he would need surgery. After surgery, based on the surgical histopathology, we know the actual stage, right? We know if he's T3, T4, whatever. And we'll also know if he's N1, N2. And then we decide, is he going to get, what chemo are you going to give him? Yeah, FOLFOX or K-POX. Okay. And then you'll have to decide 3 months, 6 months, okay, etc. Those are the decisions that you have to make. Okay. Now moving on to metastatic disease. Okay, so this picture is not there to scare you. I'm just going to show you two things. One is colon cancer is one of those diseases that has been well characterized at a molecular level. Okay, so have you ever heard of the adenoma carcinoma sequence? Yeah, so this is depicting the steps involved in from a normal colon mucosa to become a carcinoma, right? It has to become an adenoma. Then it goes through something called chromosomal instability, where you have each mitotic division has defects in the numbers of copy numbers of the chromosomes, right? And then finally, through natural selection, the ones that have a growth advantage will be selected out. That is, they grow preferentially faster than the other cells, and so on and so forth. And finally, they become a carcinoma. So that's one mechanism. There's another important mechanism which is called the MMR pathway. That is mismatch repair defects. Okay. So what is mismatch repair? You guys would have, if you go back to early biochemistry, when you look at DNA replication and there are defects, right? There are errors in DNA replication. So do you know any of the repair mechanism? One of them is mismatch repair. That is when you have repeating sequences of the same. Sometimes you can have your nucleotides which are mismatched. They bind erroneously, okay? And so within all of us, we have mismatch repair proteins. One of them is this MLH1, MSH2, a couple of other proteins are there, which are involved in correcting these repairs. So when there's a mismatch, these proteins will proofread, and if there is a mismatch, it will cut it out and match the codon to the correct sites. Okay, so that in essence is what a mismatch repair is. And if you have a defect in this mismatch repair, that is what we call DMMR, defective MMR. If the mismatch repair is normal, we call it proficient mismatch repair, or PMMR. Okay, so the MMR pathway or mismatch repair defects is another pathway by which you can have colon cancer. I'll give you an example. You guys, we were talking about Lynch syndrome, HNPCC, right? HNPCC is an inherited defect in the MMR pathway. Okay, and because they inherit the defect, they are prone for colon cancers through this MMR pathway. Okay, so in a sense, molecularly, they are kind of different from the normal colon cancer. Okay, and earlier times that didn't make a difference. You had colon cancer, you had colon cancer, that is it. But now, today, I'll show you how the MMR deficient, or another way we use the word MSI as a macrocyclite instability as a term to talk about defective MMR. So if I use the word MSI, I'm talking about the same thing. Okay, so MSI high or defective MMR both mean the same thing. Okay, so MSI high tumors today have a very different treatment from non-MSI high tumors. Okay, so we'll talk about that. And so it's important to remember that in Lynch syndrome, they are likely to have MSI high tumors. They're likely to be young. They're likely to have right-sided, that is ascending colon tumors. They may or may not have a family history. Sometimes you can have this is called sporadic MSI high tumors, right? So they may not have Lynch syndrome, but they can still have an MSI high tumor, correct? So these are the two pathways in which colon cancer develops. Now, this also is a little bit, we'll come back to this picture in a bit, but this picture represents the pathway through which the mitosis happens for a colon cancer cell. Why is this important? You'll see in the next few slides. But essentially, normally you have the growth factor receptor. This is called the epidermal growth factor receptor, EGFR. Okay, epidermal growth factor receptor, and you have to have a signal. That's the ligand. That's the green thing here. Has to come and bind to the receptor. Then the receptor will activate, and then it'll activate all these pathways. So the RAS protein, then the RAF protein, and then so on, and then finally it gives a signal for the cell to replicate. Got it? So this is how normal cell signaling within the colon epithelium happens. Okay. Now, what happens in a colon cancer cell? One is you can have excessive amounts of this receptor, okay, or EGFR overexpression. What does that mean now? With a very small amount of signal, the cell keeps on giving it the signal to have excessive mitosis, right? So it kind of abuses this pathway by overexpressing the receptor. That's one way, okay? The second way is it can have a mutation here at the RAS called a KRAS mutation. Do you remember I told you about KRAS for that patient who had a KRAS mutation? What it tells me now is that that particular patient has a mutation here, which makes this signal always on. Okay. Now, if this signal is always on, what happens? It doesn't matter whether there is a signal here or not. This is always on, so it's telling everything to keep on replicating, keep on replicating, keep on replicating. The cell goes on replicating. Got it? So that is a KRAS mutation. Okay. You can also have a problem here, or BRAF. That's the next step. If this is mutated, what can happen? Here, same thing, same concept. If this is mutated, nothing above it matters. It's always, signal is always on, so it goes on saying replicate, 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 right? So this is some of the mechanisms by which a colon cancer kind of promotes itself. The cell promotes its own growth over the other cells. Now, most of these mutations are mutually exclusive. What I mean by that is, it's very unlikely for you to have a KRAS and a BRAF. Why? Because if you have a KRAS mutation, that cell is going to grow. You don't need two mutations to happen at the same time. Okay. So how does all this knowledge help us? It helps us because we have now reached the stage where we know within metastatic colon cancers about where is that number? Yeah, about 45% can have a RAS mutation. It's a KRAS mutation. That means almost half of your patients can have a KRAS mutation. Another 26% can have a overexpression of that EGFR, which is on the cell surface, this one. Okay, so 40% can have a mutation here, another 10 to 20% can have a mutation here. Then you can have BRAF, which is another maybe 8-10%. Okay, so by identifying all these, and then a whole lot of other mutations, but by identifying all these mutations, you can find ways to target that particular person's cancer and thereby decrease the proliferation of the cancer cell. Okay, that's the idea. Although I said that, it's not as clean and clear cut as that, because you can see here MSI. Remember, I told you MSI and MMR is the same thing, but it's a different mechanism by which the cell replicates. MSI can overlap with KRAS mutations. MSI can overlap with BRAF. MSI can overlap with NRAS and so on. So what we do now is today, when we have a metastatic colon cancer present to us, we test for a few things. One is the MSI or MMR status. Okay, is it MSI high or low? I'll tell you why it's important. So the first breakpoint for us is this patient MSI high or low? The second one is the patient having a RAS mutation? Is the patient having a BRAF mutation? And then the rest. Okay, so this is the way we approach a patient. So if it's a metastatic colon cancer, is the MSI high or low? If it is MSI high, then the treatment is different. If it's MSI low or stable, then is it KRAS mutation or not, BRAF mutation or not? And then when you have no other mutation, what do you do, right? Okay. Everybody following till now? Everybody okay? Everybody with me? Okay. So the treatment earlier for colon cancer was give some chemo. Once a patient is metastatic, that's it. Okay. If we say, okay, palliation, okay, and then we give some chemo and then stop, and then give more chemo and stop. That's how it used to be, all right? But nowadays, the treatment approach has changed. The way we approach it is we look at giving some chemo initially. You can use the word induction maybe, right? Give some chemo and see if there's a response, okay? And if your disease is only in one or two places, what we call oligometastatic. Okay, the reason why that has come is because we realized that, especially in colon cancer, if you have only one or two metastatic sites and you're able to address by taking them out or ablating them out, whatever, you can improve their survival significantly. Okay, and so for example, the patient we discussed, I showed you earlier, the lady with that single liver met. Do you remember? So for a single liver met, so let me ask you a logical question. Who's going to live longer? This lady with a single liver met or somebody who comes to you where the liver is full of mets? Who's going to live longer? The one with the liver single met, yeah. And if you can, it's been shown that if you can remove either surgically or just radiofrequency ablation, or there are multiple ways of doing it, but if you just ablate that single lesion, you can improve that person's survival even more. Okay. So that's the idea. So here we're giving chemotherapy. We're trying to see if there's a response. If it becomes oligometastatic, that is something where you can ablate, then you do that. Okay. If you cannot ablate, then you kind of de-escalate. You cannot keep on giving chemotherapy. Remember the story I told you about the neuropathy and all the same problems can happen. You can't keep on giving FOLFOX for a patient forever, right? So after about 3 months, you take a scan again, see if you're not going to ablate this patient, then you kind of come down, come down on the oxaliplatin, reduce the dose, kind of make the chemo tolerable, and then continue. Okay. So this is the overall picture of the way we look at metastatic colon cancer. Okay. So first step is, so you have a patient metastatic colon cancer. Is a patient MSI high or MSI stable? So let's imagine the patient is MSI high. What happens today? Okay. So the reason why this MSI story is so interesting is because of this. Now I'll talk about this graph, but before that, I told you that there's a mismatch defect, right? So imagine a patient has a mismatch defect. So all the mismatched nucleotides are not getting corrected, and the cell replicates again, right? At the next, it's not getting corrected, it's replicating again. So what happens eventually? Eventually, you start accruing mutations, right? So these MSI high tumors have a very high mutation burden. Why is that important? Because all these mutations are going to get translated to abnormal proteins, right? And those abnormal proteins are going to be expressed on the cells as abnormal antigens. So there's a word called neoantigens. Okay. So these abnormal antigens are going to be picked up by your immune system. Okay. Now, the fascinating thing about cancer is the tumor cell knows that it is expressing abnormal cells. It's abnormal antigens. The tumor cell knows that it is expressing neoantigens, and that is vulnerable for immune clearance. Okay, and so what does it do? It hijacks by expressing something called a program death ligand, that is a PDL1, right? It expresses that. So any T cell that comes there, it causes program death to the T cell. Okay. So in these MSI high tumors, they're full of mutations. They have a lot of T cells, but no reaction because they're all being programmed to die. Okay. So now we have PD and PD1 and PDL1 inhibitors. So this is one of them. Pembrolizumab is one of them. So it binds at this synapse. It prevents this from happening. So what happens? The T cell is now able to actively recognize the tumor cell and clear it. Okay. And so this is not chemotherapy. This is called checkpoint inhibitors. People use the word immunotherapy, right? So you don't expect to see toxicities like hair fall, vomiting, nausea, or cytopenia. That's not how these drugs work. Okay. So let me ask you, now we are switching off the checkpoints on the immune system. So what side effects do you think pembrolizumab can have? Like? Very good. Okay. So you can have a immune-mediated colitis that actually mimics IBD. You can have immune-mediated thyroiditis, okay, which mimics Hashimoto's. You can have immune-mediated myasthenic syndromes. You can have, like a neuromuscular junction syndromes. You can have immune-mediated neuropathies. You can have immune-mediated ILD, okay, pneumonitis. Okay, so it's basically a whole new different set of side effects that can happen, right? But at the same time, the benefits you can see here, you can see in this graph, for those who are given pembrolizumab versus chemotherapy. Best chemotherapy means in this particular trial, all patients in the trial were randomized to receive chemotherapy versus the physician's choice of the pembrolizumab versus the treating physician's choice of whatever he thought was best chemo, right? And still pembrolizumab was better, okay? Pembrolizumab was better both in terms of progression and overall survival, right? So they stayed, the disease stayed controlled for longer, and the patients also lived longer finally. Okay, so pembrolizumab is a standard treatment for MSI high colon cancer, right? Now, if one immunotherapy is good, why not use two? Do you know what? So there's something called dual checkpoint inhibitors. Okay, so I told you about PD1, PDL1. There's another checkpoint which happens at the lymph node and the antigen processing cell. So these antigen presenting cells have a receptor called CTLA. Okay, so CTLA4 kind of enhances the T cell recruitment into the tumor. Okay, so there is a CTLA4 inhibitor called ipilimumab, right? So this trial was saying they randomized to 3 arms. One is chemotherapy alone, which is gray. The other red is the dual checkpoint. Nivolumab is PD1, just like pembrolizumab, same thing. Okay, but in addition to the nivolumab, they added this second checkpoint inhibitor. So 2 checkpoint inhibitors versus green, which is only nivolumab. Okay, so I'll just go back again. So this is only PD-1, PD-L1 inhibitor. This is PD-1 inhibitor alone, PD-1 plus, PD-L1 plus CTLA-4, and this was chemo. Now we don't, so this is presented just this year, and they showed that the dual checkpoint inhibitor was better than chemotherapy. Okay, they haven't shown this green versus gray comparison is not yet done. Okay, so we don't know whether we need both, right? We already knew that one immune checkpoint inhibitor is better than chemo. We already knew that. That is presented last year, 2021 actually. Okay, we already knew that. Now the addition of the second agent, what exactly the comparison of these two arms is not yet ready. Okay, but without going into all the details, what I'm trying to say is identifying an MSI high tumor, as you can see, significantly improves their survival, as well as does not have the kind of toxicities that you normally expect to see with chemotherapy. So patients on checkpoint inhibitors are not going to come with hair loss, not going to come with hand-foot syndrome, not going to come with cytopenia. Okay, they're going to come with hypothyroidism, sometimes worsening of diabetes. Okay, so there's a whole different set of side effects that can happen.
Both, sir.
Meaning?
Chemotherapy and
okay, that's a good question. Okay, so actually, so that's what we do here. The reason for that I tell you. Can you see this? The green is the pembrolizumab, that is a checkpoint inhibitor, right? The green arm. Okay, I'm going to this question only because he asked. Okay, all of you can jump on him later. so this green line represents the checkpoint inhibitor alone. The red line represents chemotherapy, right? So do you notice this? Do you notice that the line dropped off very rapidly in the beginning? What does that mean? What does that mean? You ask the question, tell me. What does it mean? So this is the Kaplan-Meier curve. Okay, Kaplan-Meier curve means that for every event, in this case, progression or death that happens, the line drops by a percentage. Okay, so if you find a rapid drop initially, what does it mean? A lot of events happen quickly. The event here is progression or death. Okay, so what does it tell you if the pembrolizumab arm was dropping off rapidly and then flattened out and then just remained flat? Okay, what it tells you is that this drug takes time to work. Yes, because this arm received only the checkpoint inhibitor. They did not receive chemotherapy. Okay, those who had chemo actually did better in the beginning for the first 6 months, approximately 6 months, right? It crosses over somewhere 6 months. So the first 6 months, the patients who are on chemo alone actually kind of did somewhat better. Can you see that? Okay, so why that is I told you that checkpoint inhibitors, I've shown you the picture of how it works. Generating an immune response takes time. Yeah. So until you generate the immune response, sometimes patients are, for all practical purposes, may not be on any treatment, isn't it? Because your immune response hasn't generated yet. So many times for us, we choose to give chemotherapy with this because we don't want that initial drop off. Okay, we want patients to have the benefit of chemo initially while you're waiting for the pembrolizumab to start working. Then after 6 to 8 weeks, we expect the immune response to have mounted. So sometimes we stop off or really come down on the chemo and just continue the pembrolizumab. Okay, so yes, we do combine both, and this is the reason why. Okay. Okay, so I'm moving to the last sections of my talk. Yeah. So now moving to the MSI stable or the proficient MMR part. Okay, so I told you we start off by saying is it MSI high or MSI stable. Finish the MSI high part. We talk mainly with checkpoint inhibitors. For the MSI stable, what all can we do, right? So here we can give the conventional chemotherapy. So I told you we choose between a few agents. One is the 5-FU or capecitabine, which is the oral form of 5-FU. There are other agents here which I haven't mentioned, but essentially this 5-FU and its related groups of chemotherapy drugs are the main backbone on which we do our chemotherapy. The second agents you can choose from are the platinums. We mainly choose oxaliplatin. Okay, and the third group of agents are the topoisomerase inhibitors, of which we mainly choose irinotecan. Okay, so That's all many new drug names I know. But essentially what we're doing is we're combining drugs from each of these classes. So we can do 5-FU plus oxali called Folfox. 5-FU plus oxali is called Folfox. Or you can do 5-FU plus irinotecan called Folfiri. Okay. Or we can do all three, which is called Folfoxiri. Okay. So you got the names? Okay. So Folfox, Folfiri, Folfoxiri, right? Or you can do capecitabine with oxali called Cape-Pox, or capecitabine with irinotecan called Cape-Iri. Okay. So that's essentially what we do. So we kind of choose between these three. We pick out what we think the patient. There are good and bad of each drug, obviously. So we kind of choose between that. Okay. So that's about the cancer therapy. Now, additionally, we have the option of using certain targeted inhibitors. And this is where the knowledge of whether it is RAS, RAF, blah, 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 all that becomes important. Okay. For example, if you have a patient who is got a overexpression here, right? Then you want an antibody that binds and blocks off this signal. Okay. So those are the EGFR inhibitors. So you have cetuximab, panitumumab, two drugs that we use. So we use the chemo plus this one, which will then improve the efficacy of the treatment. Okay. So we use any of the chemos I mentioned above. We add this drug to that combination so that we have a better efficacy. Got it? Next is, it's not in this picture, but one of the main receptors apart from this through which colon cancer grows is the VEGF, vascular endothelial growth factor. Okay, so there's a drug called bevacizumab. Okay, so we can combine chemo with bevacizumab, again improves efficacy. Okay, and these combinations is what we mainly use for colon cancer treatment initially. So I'll stop there. I'm happy to take questions from you guys.
So mucinous cancers won't be picked up by actually. Usually, as a protocol, do you do imaging first or biopsy? Because we'll not know if it is mucinous after doing the effects.
Yeah, so as a protocol, generally, if you're suspecting colon cancer, we don't do PET as the initial investigation. CT scan, okay, and then colonoscopy and so on. Okay. Since you asked this important question, I had based on time, I had one slide, etc. I have 5 more minutes. Okay, so I have one more slide. Don't get freaked out. I won't go through the whole thing, but this is talking about rectal cancer. It's slightly different from colon cancer in the only way that rectal cancer within the pelvis, because there are so many bony structures and all that, and you also need to know exactly where is the extent of disease. A CT scan is not enough. So we need an MRI of the pelvis as well. Okay. So that's where this comes in. So you do the usual CT we do to evaluate the thorax and the upper abdomen and liver and all that to see if there are metastases for rectal cancer. But additionally, we will do a pelvic MRI to stage the local site of disease, because from the surgeon's perspective, they need to know, from our perspective, we need to know, is it involving any of the pelvic structures? Okay. Because infiltration to bowel, for males, infiltration to prostate, for females, infiltration to vagina, all those things can happen with rectal cancer. So that's slightly different from colon cancers. So to answer your question, PET is not the standard imaging that we normally do. We do a CT, okay? For a rectal cancer, we would additionally do a MRI of the pelvis, okay? And then of course, scope is to evaluate the site of disease and biopsy, okay? For a rectal cancer, the colonoscopy has to also evaluate the rest of the colon. You can't just do a colonoscopy, find something in the rectum and stop there. Ideally, they should go past that mass, go all the way to the ileocecal junction and evaluate the rest of the colon. You can have synchronous metastases, right? So synchronous primaries, not metastases, synchronous primaries within the colon and rectum. So you need to evaluate the whole colon. Okay. Any other questions?
At least for how long? Like, it is for 1 year, cycles and how long?
How long? Okay, yeah. So in general, 6 months. There are some patients for whom we give only 3 months. This is for non-metastatic disease. For metastatic disease, since it's a systemic disease, we would continue treatment for, there's no fixed time. We kind of give initial 3 months, then we come down we give them only oral tablets for some time. Then when the disease picks up again, we give them another set of treatment like that. So it's a more chronic, think of it like a chronic disease.
Okay, for the first case that you mentioned, the 24-year-old guy who had cancer, he has family history of malignancy. So do we see a lot of non-inherited young age colorectal cancers now?
Yeah, we do actually. So young onset colon cancer is colon and rectal cancer is a major problem. So with practice itself, the median age is 45. So whereas when you look back at your textbooks and you read, you see colon cancer as a older person's disease. Even if you see Western literature, they say median age is 60 plus. But that's not true for us. So is that only a local thing or is that a global thing? Is the overall age of colon cancer coming down? Those are questions that are trying to be answered. But within our practice, we see a lot of young people having colon and rectal cancer.
Do a lot of them have this MSI problems, or is
Yeah, so let me answer that. So familial colon cancer, that is right at the top. Okay, so familial colon cancer is not that common. It does not, you don't get a family history out of most of our patients. Only 10-15% will give you a family history of colon cancer, right? Many times you will not have that history, but yet almost 20% of patients may have a MSI high disease. Okay. Tell me.
Is there a role for screening? If so, what is the value screening for family cancer? Is there a role for screening, or like is there a guideline to say that we should be doing colonoscopy, or is there a approach towards someone who comes with concerns like that? I have a family with cancer, first degree. So we do.
Yeah. So for those with family history and first degree relatives, the guideline is to do a colonoscopy 10 years prior to the age of presentation of that family member. Okay. So you should start at that age. If they are, as long as they are not Lynch syndrome. So everybody else can do colonoscopy screenings once in 5 years at 10 years prior to the age of presentation of the relative. For Lynch syndrome, it's called hereditary non-polyposis, right? So they actually need yearly cancer screening. So remember that slide I showed you about molecular pathogenesis, right? So the adenoma to carcinoma sequence takes 10 years, okay? So you don't have to screen that frequently, okay? But for a mismatch deficiency, the adenoma carcinoma sequence is completely bypassed. They can have a cancer develop even within a year. So you need to do yearly colonoscopy. So for Lynch syndrome, which is MSI driven, you need to do yearly colonoscopies. For everybody else, you don't need to do that. You can do once in 5 years.
should we consider an early screening, like for general population, generally you say after 60, you should consider screening. So now that our median age group is shifting, should we consider early screening for a population that's coming to if they
That's a good question. So I don't think there is any evidence to say early screening improves outcomes. You shouldn't do a screening unless it's going to improve the outcome, right? There is definitely data saying that 60 plus patients should have colonoscopy screening. But let me ask you a question. How many of you have family members who are 60 plus who are doing regular colonoscopy screening? Hardly anyone, right? Because it's so inconvenient, right? It's so difficult to motivate yourself to go to a hospital and do a colonoscopy screening when you don't have symptoms.